So thank you, Tony. So I'd like to just ask you, with your excitement about the IOM roundtable taking up this topic, what do you see as the opportunities for a roundtable to weigh in or make a difference in this whole area?
Yeah, thanks, Martha. I think that the one thing that's really exciting is to actually corral and organize the evidence base for essentially community organizing as a strategy to improve public health. I think that the evidence base it's out there, it's diffuse, it's around social capital and it's around collective efficacy. And it would be great to sort of organize that and to make it sort of accessible for people that are trying to do this work. Because right now, for the most part, we're doing this on gut instinct. For the most part, I don't want to say that there isn't evidence, because I believe that there is. I just don't think that public health has applied itself to trying to figure out where the evidence is and how it applies to improving health outcomes. And so having the legitimacy of the Institute of Medicine, CDC and others fully trying to understand this based on what the science has shown, looking at parallel movements in other fields, education, poverty alleviation, community and economic development, I think would be very important to the field of public health to help, for instance, public health departments that are a little bit squeamish about, talking about power or racism or the legacy of a whole host of past practices that create the conditions that we're trying to treat with pamphlets and brochures. We need to support them and help them be emboldened to engage with their communities in ways that are explicit about building power.
Really wonderful comments about the role of all the isms in terms of determining the situation that we have in our hands today with regards to health equity. One of the challenges, though, for many of our communities, for many of our most impoverished communities, is that, unlike California, many of our jurisdictions don't have that kind of economic base, that well-diversified economic base upon which you can draw in order to develop private-public partnerships. Most of our counties, our impoverished counties, are places where small employers are the employer base. Mm-hmm. And so the challenge for us at that level becomes, how do we harness the existing resources, but then how do we tap into national streams that might be able to potentiate what we're doing? I wonder if you have any advice about that.
Yeah, no, that's a great question. It's a great challenge, actually, in the work that we're doing in California. About half of our 14 communities are urban, the other half are rural. And you see strengths and weaknesses in both of those settings that are interesting. In the rural settings, we find that exactly what you described, lack of infrastructure, lack of economic diversity, so there's not much of sort of an employer base. But what you do have in rural settings that you don't have as easily in urban settings is the ability to move across sector fairly easily. People, officials, leaders in those communities tend to wear a lot of different hats. So they're much more at ease sort of walking across sectors. They're much more at ease in collaborating. And that's a real strength in a rural setting, to leverage the assets that you really have, which are the collaborative capacity that exist in those places, so that you don't have to. When I was the Alameda County Public Health Director, one of the first things I wanted to do was go meet with the Oakland Superintendent of Schools, because I felt like, public education, public health, they were sisters, and that we had to sort of find common purpose. It took me about 6 months to get a meeting with the Superintendent of Schools in Oakland. It happened to be a receiver that was the state had imposed on the school system. So I was delayed in even making an introduction for about 6 months. In our rural communities, you have the mayor also as a school teacher. So you have this ability to essentially forge these cross-sectoral linkages and really take full advantage of the scarce resources that are available. But there are resources there. So I think human capital resources, the ability of people to leverage their relationships to use resources in the most effective way, is something that rural communities have to their advantage that should be essentially taken advantage of.
Hello, hello. I'm Connie Mitchell. I'm health officer in the new Office of Health Equity in the California Department of Public Health. I also oversee our Health and All Policies Task Force. So I want to publicly acknowledge and thank the endowment for the support you've given to help us staff and start up that endeavor, and it's really taken off. So thank you very much. Our Office of Health Equity is adopting the framework that you've proposed, and our first report that we're working on is not about the disparities, but about the inequities. And we have a specific charge to define and describe the inequities. So I have a couple of questions. One is, are we going to really be able to get this report out? What are going to be our pushback? And I perceive from your model that changing the narrative is the most difficult step. And that makes me really nervous because people don't realize that their internal narrative is there, and they don't realize how much it's driving their daily activity. And to challenge their own personal narrative, they're going to really push back hard. So I just, you've been out and about and you've been talking to different communities. What's it going to look like? How's it going to present itself, this pushback?
Well, first of all, I congratulate you for taking this approach, and I encourage you to be provocative. Not just, to get attention, but because you don't really have much hope of making change unless people feel a little bit uncomfortable about this. And so you have to provoke people. You have to shake them up about, their sort of understanding of what's happening and how it happens. The other thing that you have to do around narrative is you have to embrace the dominant narrative. But then you have to expand it. You can't say this is not about personal responsibility. You can't say this is not about access to health care. Even if those things don't matter, and they do, we've invested so much time and effort, and people have invested their entire careers in these things. I've invested half of my career in it. So it feels like you're dismissing those efforts. And I think that that's just a poor tactic, never mind wrong. So you have to embrace these things and then expand them. Yes, this is about personal responsibility, but personal responsibility is nested in community responsibility. I mean, tell stories about people who are trying to exercise or, eat healthy, and everywhere they go, all they find is junk food. When they try to exercise, they try to do the walking that's being encouraged, they can't because there's bullets flying. So, that's a compelling story. Here's somebody trying to be responsible whose environment is actually conspiring against them. So I think it's important to create a narrative that invites a lot of people to think differently about health. You have to provoke them a little bit, but you also have to embrace their sort of core understanding that's unshakable. There's nobody you can convince in the final analysis that personal responsibility doesn't matter. I mean, of course it matters. It matters a hell of a lot. But it's not the only thing that matters. And so I think that allows people to sort of relax and see that you're not trying to, disrupt and discount everything they've ever believed. You're just trying to sort of broaden it and think more innovatively about strategies that can be adopted that are not necessarily health strategies in the case of your work. They're non-health strategies that have profound health impacts. I think people, in my experience, people welcome that as long as you don't confront and deny their core belief and value structure.
It's great advice. Thank you.
Thank you.
Thank you so much. We're getting so much to think about and program into our work. So now we'll invite up our second panel of the day. And I'm going to turn this podium over to Winston, who is the Clinical Director for Community Benefit at Kaiser and a member of the Health Equity Roundtable, to introduce the panel and chair this session. Thanks, Winston.